Yeah, hello, good evening, everyone. My topic is on neurological weakness. So, the basic goal of this topic is to provide like a more of a organized structure on how we approach weakness, so that we can like categorize weakness, so that we can arrive on a easier diagnosis. So the topics we'll be covering are the pathways. By pathways, I mean the upper and the lower motor neuron, the way they start from the cortex, go through the spinal cord, and finally reach the muscle. Common nomenclature used with weakness. This includes terms that are often confused with weakness, as well as like certain terms associated with tone and such. After that, we move on to the components of motor examination, which is we commonly do on a clinical practice. And finally, we'll see on how we can localize a site of pathology in a weakness. So by localizing the site of pathology, we can actually arrive at a diagnosis much easier. And finally, we'll go through an algorithm that will help us better manage a case of weakness, seeing what investigations to order. So moving on, first we'll go through the UMN pathway. So the corticospinal tract starts over here. So it starts from premotor area 4. So the neurons from here start and make the journey down. So once they make the journey down, they tend to stick to this side of the brain. At the level of approximately the cervicomedullary junction, 70% of fibers tend to decussate. They decussate and go to the opposite side, forming this tract, the lateral corticospinal tract. So now the lateral corticospinal tract predominantly innervates the bilateral, it innervates the distal muscles comprising mainly of the limbs. So from the corticospinal tract, the remaining 30%, they tend to form the ventral corticospinal tract. The ventral corticospinal tract tends to continue along the same side down, and it innervates more of the axial muscles. Now, one component of motor is from the cortex to the spinal cord to the peripheral muscles. The second one is the corticobulbar. Corticobulbar, as the name suggests, starts from the cortex and it goes down towards the brainstem, and it innervates all the lower motor nuclei of the cranial nerves from 3 to 12. So one important thing to understand is like the corticobulbar tract tends to have bilateral innervation for most of the cranial nerves except for 7 and 12. So for 7, usually the lower portion of the face, it tends to have only a unilateral innervation from the opposite side, which is why you tend to have weakness of the face in CVAs involving the lower half of the face. And at the same time, they tend to have weakness of the tongue as well. Now, all these tracts are the corticospinal, meaning they start from the cortex and head down. The remaining nuclei are the bulbospinal tracts. So, the bulbospinal tract is also what we call the extrapyramidal system. Now, there are four major ones. One starts from the red nucleus. The red nucleus, this is the rubrospinal tract. So, the rubrospinal tract starts from one side, it decussates and goes to the opposite side. Whereas the remaining three, which is reticulospinal tract, vestibulospinal tract, and the third one being a tectospinal tract. They tend to continue down the same side. So on your from the bulbospinal tract, rubrodecussates, whereas the remaining three tend to head down in the same direction. Now, the corticospinal tract mainly deals with your movement and functioning of the muscles, whereas rubro and the remaining three, which is the bulbospinal system, mainly focuses on the tone and mainly accessory functions instead of movement as such. So the main function is facilitating tone. And out of the three, the red nucleus tends to focus more on the limbs. It regulates the tone of your limb muscles, whereas reticular, vestibular, and tectospinal focus more on the axial muscles. Uh, so this is like a basic overview on the UMN pathway. Now, coming on to LMN pathway. So this is a basic diagram showing the two motor neurons, an alpha motor neuron and a gamma motor neuron. So basically, your corticospinal tract would come down and it would innervate over here. So your brain would give a signal and it would go into your alpha motor neuron. And the alpha motor neuron would discharge and innervate what is known as the extrafusal muscle fibers. Now, the extrafusal muscle fibers are your basic sarcomeres and are involved in muscle contraction, whereas your gamma motor neurons innervate what is known as intrafusal or muscle spindle. The function of the muscle spindle is to maintain muscle tone. So when a gamma motor neuron discharges, so if this is how a spindle actually looks. So on a spindle in the center you have a sensor, and on the peripheries you have like muscular component. So the gamma motor neuron innervates the peripheral component. So when it discharges, it actually causes this peripheral component to contract, causing a stretching of the intrafusal fibers. So this stretching is carried back by the afferent neuron, which constantly senses the tone. So a discharge from the gamma motor neuron tends to increase the tone of the muscle. So this is the basic arc of your stretch reflex. So whenever a muscle is stretched, it's picked up by the afferent neuron, and it tends to stimulate the alpha motor neuron, causing a contraction. So this is the basic overview of the element pathway. Now, coming on to common nomenclature that we associate, the term weakness medically is associated with what we call power. Now, when a patient comes, they tend to present with weakness, but it may not be a true defect in power. The other common things they present with is easy fatigability, which can happen in cases of anemia or hypothyroidism. The difference is if you were to examine the power, it would be 5 by 5, but then they would have a difficulty in sustaining that power, which tends to have a decremental trend over time. It's also seen in patients with arthritis or other painful conditions. The other term is bradykinesia. Now, in bradykinesia, the ultimate peak that they hit of power. So they tend to hit, like if this is a normal person, they tend to hit. Uh, yeah. So the peak of power tends to be hit fast in normal person, whereas in bradykinesia, the curve tends to be prolonged before they can actually hit that sweet spot of power. Sorry. Yeah. So this would be the curve in a bradykinesia. So they tend to hit the maximum power on a much later stage. The fourth and final thing is apraxia. Apraxia is the inability to do learned activities. It's commonly seen in frontal lobe lesions. So if a person can do all their normal motor functions, but if you ask them to do something, they will not be able to do it. Like if you ask them to write a particular word, they won't be able to, but on their own free will they can pick up a pen and they will be able to write. The same thing goes for apraxia of motor activities, can apply for speech as well, where if they're asked to say a certain thing they might not be able to. So these are the common terms that tend to have some gray area with weakness. Now, moving on to the third section, which is motor examination. The common components that we see in a motor examination are power, bulk, tone, and reflexes. So we'll just go through each one quickly. So coming on to power. So power has a total of 5 grades, and the fourth grade it's split into a minus and a plus. So basically, a 5 is a full power, a 0 is absolutely no movement. Coming on to a 3 is movement against gravity. Okay, so that leaves 1, 2, and 4 in between. Now 4 is movement against resistance, and that can also be classified into three: the basic 4 that we know, and a 4 plus and a 4 minus. A 4 plus is movement against strong resistance, but not full power. So it tends to become clinically difficult to distinguish this, which is why we generally stick to a normal 4. But you can usually distinguish it by comparing to the opposite side. It tends to be difficult when there's a 4 plus bilaterally. Same thing, a 4 is moderate resistance, and a 4 minus would be a mild one. And 3, as I mentioned, is a movement against gravity, and 2 would be with gravity eliminated. So if this is your leg, so moving it up would be with gravity, whereas moving it on the bed itself from side to side would be with gravity eliminated. So, and one is basically like any flicker or any mild contraction that you see with no associated movement across any joint. So the muscle tends to contract, which you can visibly see, but doesn't have any purpose. That would be a grade 1. Coming on to tone. Now, tone could be hypotonia, which is a reduced tone, which is classically seen in element lesions or in later stages of muscular dystrophies and myopathies, or an increased tone. So, in increased tone, there's generally three types that are described. It's a spasticity. A spasticity is commonly seen in your typical pyramidal lesions. So it's described as a clasp knife nature. So basically, what happens is when you're testing testing tones, say in the upper limb, and you're moving across the elbow joint, there's an initial resistance when you're extending, and then a sudden release. This is called a typical clasp knife. The idea is your tone is predominantly exaggerated in the flexors. Similarly, in the lower limb, if you were to test, the tone would be more in the extensors. So if you were to try to extend at the knee joint, you would have an initial resistance followed by a free flow. Now, coming on to the second one, which is rigidity, it can be of, it's typically said to be a lead type, plastic, or cogwheel. So the idea is it's seen mostly in extrapyramidal lesions. Sorry. Yeah, it's seen in extrapyramidal lesions. So in rigidity, the idea is there's an equal increase in tone of both your flexors and extensors. So it tends to have a uniform resistance throughout the range of movement. Now, a lead pipe rigidity you typically see across the elbow joint. So when you're trying to extend the elbow joint, you would see a lead pipe rigidity in both the directions. Whereas your typical cogwheel rigidity, you see it in the wrist actually. So if this is the patient's wrist, when you ask them to rotate the wrist, you will see like a jerky movement when they're going clockwise. That is called a typical cogwheel. And the final term is a paratonia, also known as a Guggenholten. It's seen in frontal lobe lesions. So what happens here is there's a increase in tone of both flexors and extensors, but the amount of resistance given by the patient is corresponding to the amount you try to move the limb. So suppose you're trying to extend the limb and you use minimal force, you'll find that the resistance is less. So when you try to increase the amount of force you use to move the limb across the joint, the tone tends to increase. It's almost as if the patient is resisting the movement. So yeah, these are three types of tones that you commonly see. Moving on to the next component, which is reflexes. Reflexes has five grades. Zero being absent. Four is clonus. Clonus is a rhythmic jerking movement which you see. Now the common types of clonus you see are the ankle clonus and patella clonus. You can elicit an ankle clonus by, suppose this is the foot. If you sharply dorsiflex the foot, you would see a clonus across the ankle joint, where the foot starts oscillating up and down. Whereas a patella clonus, if this is the patella, this would be your thigh and your knee, your leg below it. If you were to sharply push the patella down, your quadriceps would start contracting on a rhythmic fashion. So that would be a patella clonus. And this is the one extreme, which is 4 plus, and the other extreme is 0, which is a completely absent reflex. And in between, you have 1, 2, and 3. 2 being your what you see as a normal reflex, 3 being an exaggerated reflex, and 1 being a weak reflex. Um, so you tend to see an exaggerated or clonus typically in UMN lesions, whereas you see absent or weak one in LMN lesions. A normal one can actually tend to happen in any of them on the initial stages. Now, coming on to the important part of the topic, which is localizing the site of pathology. So, when a patient presents to you with weakness, so you need to have more of a structured approach so that you can narrow down the site of pathology so that you can arrive at an easier diagnosis. So, to do this, what you look at are the characteristics of weakness, the associated signs with weakness, and the typical distribution of weakness. So, we'll go through one by one. The first one being characteristics of weakness. So, if when any patient comes with a weakness in a muscle, you try to distinguish whether it is a UMN nature, LMN nature, or a myopathic nature. So, coming on to the left hand side of the box, there are mainly six components that you look at. So, in a UMN lesion, there tends to be no atrophy at all, whereas in an LMN lesion, the atrophy is severe, and in a myopathic lesion, it tends to be mild. So this is one important distinguishing factor. The second is fasciculations. Fasciculations are seen only in element lesions and are not seen in either one of them. Tone, as I mentioned before, is increased and spastic in UMN, whereas it can be decreased in element. And myopathic in its initial stages tends to be normal. Because, as you know, myopathic tends to involve mainly the extrafusal muscle fibers, whereas the intrafusal are usually intact. But in the terminal stages, tends to become decreased. Now, distribution of weakness will go through separately, but then on a more of a general basis, a UMN lesion tends to have a pyramidal, which is what you call as hemiparesis, whereas an element lesion tends to have distal involvement, like muscles of your hands or foot. whereas myopathy typically involves your proximal muscles. Now, coming on to reflexes, I mentioned before, you tend to see a 3 plus or a 4 plus reflex in a UMN lesion. You tend to see an 1 plus or the absent reflex in LMN. And once again, in myopathy, since the involvement only at a later stage tends to produce a decrease in tone, it tends to produce a reduction in reflexes as well, only at a very late stage. The final one, which we commonly test, is a Babinski sign, which is basically your plantar going up. So this is Babinski is a superficial reflex, which is typical of a pyramidal lesion, whereas this would naturally be absent in a lower motor neuron lesion or a myopathic lesion. Now, coming on to localizing the site of pathology. So, so basically, the idea of this is to see the associated symptoms. So this table gives the associated symptoms that helps to localize the exact site of pathology. So let's focus on each one individually to have a better understanding. Okay, so cerebrum. So the idea is whenever there's a weakness, the pathology doesn't focus on targeting only one particular system. It tends to be in that location, but it damages things in and around it. So when you think about cerebrum, you think about higher mental functions, okay? And you think about visual functions, you think about speech and things like that. And even the extrapyramidal system, the basal ganglia is all associated with the cerebrum. So, when a patient with weakness has an associated change in mental status or sensory abnormalities, since areas number 3, 1, and 2 is seen in the cortex, visual field abnormalities, and as I said, basal ganglia lesions, so movement abnormalities. So, this is not a hard and fast rule, but it tends to point towards more of a cerebrum involvement. Now, once you're done there, you come a bit down, you come to the region of the brainstem. So, so any weakness associated with cranial nerve abnormalities should definitely point towards a brainstem involvement. The typical lesion where you see a cranial nerve involvement in the cerebrum would be an internal capsule infarct where you have facial weakness. But as I mentioned, only cranial nerves 7 and 12 tend to have unilateral innervation of the element neurons from the cerebrum. So suppose you see a weakness with probably a sixth nerve involvement or let's say a third nerve involvement, you would definitely be suspecting a pathology in the brainstem. A third nerve being a midbrain pathology, and a sixth nerve being probably a pontine pathology. Now, coming further down to the region of the spinal cord. So, when you have a lesion of spinal cord, the spinal cord is generally a small area. So you have multiple tracts that tends to be clustered with your cortical spinal tract anterior, your sensory tracts posterior, your lateral spinothalamic tract. So when you have a lesion, it tends to involve multiple things in a small area. So you will have weakness with typically with sensory abnormalities. And one interesting feature is whenever there's a lesion at a particular level of the spinal cord, say at T4, T4 to T6 is damaged. So at T4 to T6, you will have element signs because the motor cranial nerves are located over here. But below it, you'll have a UMN signs. So you tend to have a mixed combination of both LMN and UMN, which is typical of spinal cord lesions. Along with that, sphincter dysfunction is usually typical of a spinal cord pathology. Now, coming further down, once you've reached the spinal cord, the next step is the nerve roots, finally the nerves, neuromuscular junction, and muscle. Now, we'll go down first to muscle. Now, what is typical of a muscle and a neuromuscular junction involvement is sensation. A sensation is typically always paired in lesions of both of them. Now, a neuromuscular junction and muscle, to differentiate both is kind of difficult. But neuromuscular junction, the thing is, it's typically seen in myasthenia and Lambert-Eaton, and you tend to have ptosis, diplopia, and dysphagia, like basically involvement of nerves, cranial nerves. It appears to be involvement of cranial nerves. So this kind of doesn't correspond with the localization of the pathology. So this helps differentiate a typical myopathy from a neuromuscular junction lesion. And both neuromuscular junction and muscles tend to predominantly involve the proximal more than distal. Now, coming on to the middle two, which is spinal roots and a peripheral nerve. Now, spinal cord pathology, like radiating limb pain, is typically seen in a disc prolapse or something, which tends to compress on a nerve. And since a whole root is involved, there's both a motor and a sensory component. So, since a motor and a sensory component is there, it helps distinguish pretty well from a neuromuscular or muscle lesion. Now, usually a peripheral nerve lesion tends to be more slow and chronic and more distal because usually peripheral neuropathies are length related, which is why you get a typical glove and stocking neuropathy in diabetes. So, yeah. So in this as well, there'll be a mixed weakness as well as sensory abnormalities. And since it's a element lesion, as we saw before, there would be loss of reflexes. So just going to summarize the whole thing. So if you see a weakness with yeah, so if you see a weakness with higher mental functions, you think cerebrum. Weakness with cranial nerves, yeah, weakness with cranial nerves, you would think brainstem. A weakness with sphincter involvement or a mixed element in UMN, you would think spinal cord. And weakness with absent reflexes and an element type palsy with atrophy, fasciculations, and a reduced tone. Along with sensory involvement, you would think of a peripheral nerve, spinal root, or a peripheral nerve lesion. Whereas weakness of element features with atrophy and reduced tone, along with a normal sensation, you would think of a neuromuscular junction or a muscle involvement. Yeah. Now, coming on to the third component. So basically, what we've seen so far is how to distinguish element from UMN. And once you do that, you tend to localize whether it's a cerebrum or a lower down involvement. And the third key component is distribution of weakness. So distribution of weakness could be hemiparesis. I'm sure everyone is familiar with these terms, so I'll just go through them quickly. Hemiparesis, which is one half of the body, para being both lower limbs. Now, an interesting thing is quadriparesis versus generalized weakness. The term quadriparesis is typically used with a UMN involvement, whereas generalized weakness tends to be used with the LMN involvement. So in both of them, all four limbs are involved, but quadriparesis you typically use when you have an increased tone in UMN features, whereas you use generalized weakness when there are element features. Monoparesis being one limb. Under monoparesis, you can have a distal proximal involvement. And weakness in restricted distribution is typically seen when a particular radical or nerve root is involved. Now, coming on to temporal subclassification. So, when you have, suppose a patient comes with hemiparesis, you tend to ask how long the duration was. It could be acute being a few minutes to hours, subacute meaning days to weeks, or chronic being months to years. Now, a temporal subclassification once again helps to narrow down the etiology. So, if you have a patient presenting with hemiparesis, which is of a minute's duration, you would think of a typical CVA. Whereas, suppose you have a patient presenting with a chronic hemiparesis that tend to occur over the span of months or years, you tend to think more in the direction of a degenerative disorder or a neuroplasm. Similarly, with paraparesis, the patient had acute paraparesis. The more common medical differentials ruling out trauma would be a possibility of transverse myelitis or a spontaneous, or in patients with thrombocytopenia or bleeding disorders, maybe a spontaneous extradural hematoma that could be causing compression of the cord. Now, the thing about paraparesis is it typically is caused by spinal cord lesions, but there are certain exceptions where a paraparesis can happen because of a cerebral involvement. This is typically seen in ACA infarct. So there's a specific entity called the unpaired ACA. So usually your anterior cerebral arteries tend to run in two, but in some anatomical variants they tend to be singular. So an occlusion of a singular anterior cerebral artery would cause infarction of both the paracentral lobules. So that would cause paraparesis even though there's only a cerebral involvement. Similarly, a cortical sinus cortical venous thrombosis involving the superior sagittal sinus as well can cause a paraparesis. So, so basically, I'm just giving like a few examples on how you can like categorize the lesion, like according to the temporal classification. So yeah, now we'll go on to the final management algorithm. So now first, what you see based on a distribution of weakness, whether it's a hemiparesis, paraparesis, you tend to evaluate further and see what will be the more appropriate initial investigation. So we'll focus on one at a time. So when you see a hemiparesis, the lesion is typically it tends to have human features. We directly go for brain CT or MRI as we usually do. Whereas if you see a paraparesis, you tend to look whether it has a UMN or element signs. So once it has UMN signs, you look for cerebral signs. As I mentioned before, associated symptoms. So if you have a UMN features with cerebral signs, your pathology tends to be localized through the cerebrum. So you directly go for a CT or MRI brain. But if you have a UMN lesion in a paraparesis with no cerebral signs, you would be justified in thinking it's a spinal pathology because that is the most common reason. So you would go directly to a spinal MRI. So now this is if you see a paraparesis with UMN lesion. Now, in case you have paraparesis with LMN lesion, so your pathology tends to come low down. It's probably a nerve root or a peripheral nerve. So the test in that stage becomes a EMG or the NCS. So once you see a paraparesis with element signs, what you're saying is you're basically ruling out involvement of the spinal cord or above. So you tend to evaluate below, and the evaluation below is the EMG or the NCS. Now, coming on to quadriparesis. Now, in quadriparesis, as I mentioned, the term it can be distinguished into quadriparesis and generalized weakness. Generalized weakness being what is seen here as LMN, and quadriparesis is what we see here as UMN. So in a quadriparesis patient, first you check for sensorium, whether the sensorium is intact or not. So if the sensorium is not intact, you will be suspecting involvement probably in the CNS. So in patients with severe shock or injury, what happens is they tend to go for global cerebral hypoperfusion. So since all your cerebral neurons are not getting blood flow, they tend to have weakness in all the four limbs. And in that case, the pathology tends to be in the brain, which is why you go for the MRI or CT brain. But if the patient is having a normal cerebral function with quadriparesis, the pathology is probably high up in the spinal cord. So you tend to go for a spinal MRI, more specifically a C-spine involvement. So probably a transverse myelitis or a tumor or probably an extradural compression can all cause a quadriparesis at a high cervical level. Now we finished three of them. Now coming on to monoparesis, a single limb involvement. So in the monoparesis with UMN signs, this it's typically uncommon to see a monoparesis with UMN signs. There are only a few conditions that can cause this. So since there are UMN signs, it's suggestive of either a spinal or a cerebral involvement, which is why you go directly for the MRI visualization. Whereas if you see an element sign, which is more typical of a monoparesis, you would go for EMG or NCS because that would make sense because there's probably a nerve root or a singular nerve involvement. Now, once you see element signs and take a EMG or NCS, even in that you can have three different patterns. You can have a UMN pattern. So if you have a UMN pattern, you tend to go towards the MRI of the brain or the spine. So because if there's a UMN pattern, it's obvious that it's an involvement of something higher up. So you tend to image over there to see if there's any pathology. Whereas if you get an element versus a myopathic pattern, an element pattern, as I mentioned before, is seen in a nerve radical or a peripheral nerve disease, or it's seen in a muscle or a neuromuscular junction disease. So basically, to summarize what all we've seen, so when a patient comes with you to weakness, the first thing you would look at is the characteristic of weakness. So when you determine whether they have UMN, LMN, or a myopathic feature. So once you've done that, the next thing you look for is associated symptoms. Is it cerebrum? Do they have cranial nerve palsies? Do they have loss of reflexes? Is sensation intact? So that will help you determine the localization according to this classification. So now once you've done that, the next thing you look at is distribution. Is the patient having a hemiparesis, a paraparesis, or a quadriparesis? So once these three things are done, you look at the temporal subclassification, whether it's acute, subacute, or chronic. So when you approach weakness in the systematic fashion, it tends to like narrow down a differential diagnosis and like really like give you like a better idea on what the patient has, on how you can evaluate the patient. And so finally, we saw like what investigations to order for a patient with weakness. The basic gist of the algorithm is when a patient has UMN signs, you're thinking brain or spinal cord, and you go for the MRI visualization. Whereas when they're having element features like atrophy, fasciculations, or reduced tone, or impaired reflexes, you tend to think the pathology is related to either the nerve or the muscle. So you go for EMG or the NCS. Yeah, and this is the summary that I mentioned. You look at the onset of weakness, whether it's acute, subacute, or chronic. Then you check the distribution. Is it a hemiparesis, a monoparesis, a quadri, or a paraparesis? Then you check whether there are UMN features, element features, or myogenic features. And finally, you check for symptoms that are associated with the weakness to give you the complete diagnosis. Okay, so now we'll go through a couple of cases so that we can actually like use what we've learned over here in real life scenarios. So the first case is a 57-year-old male who presented with a 3-month history. So right off the bat, a 3-month history means it's we are dealing with something that's chronic. Okay, so a 3-month history of weakness in his right arm, and he experienced progressive right hemiparesis. So we come to the second component of the diagnosis. So we have a chronic lesion that is causing right hemiparesis. So now we move on to examination. On examination, you find that the power is 4 by 5 on right side and the 5 by 5 on left side. So it's slightly reduced on the right side. And tone is showing a clasp knife nature with increased reflexes. So when we're seeing this, it's obvious that we're looking at UMN features. So now we have three components to our diagnosis. We have
Your voice is not audible, Ram. Preetham, your voice is not audible, Ram. Preetham, your voice is not audible, Ra. Preetham, can you hear me? Hello? Can others hear me? Can others hear me?
Yes, you're audible.
So basically weakness அப்படின்னு பார்க்கணும்னா weakness of how what is it that you want to see in a weakness? சரியா? First you have to confirm the patient is having a neurological weakness. So before that அதுக்கான சொன்ன மாதிரி பேஷண்ட்டுக்கு வந்து நாட் ஓன்லி திஸ், பேஷண்ட்டுக்கு வந்து பவர் டோன் பல்க் மட்டும் இல்லாமல் அதுக்கு முக்கியமாக முன்னாடி பார்க்க வேண்டியது ஆட்டிடியூடு. ஆட்டிடியூட் ஆஃப் த லிம் எப்பவுமே பார்க்கணும் சரியா? பிகாஸ் மோஸ்ட் ஆஃப் த டைம் இந்த லோவர் லிம் மோனோபெரசிஸ் அன்யூஷுவல் ப்ரெசன்டேஷன்ஸ் எல்லாம் ஃபர்ஸ்ட் லோக்கல் காசை ரூல் அவுட் பண்ணுவாங்க. இந்த லோவர் லிம் மோனோபெரசிஸ்லாம் வந்துச்சுன்னா ஃபர்ஸ்ட் ரூல் அவுட் ட்ரை டு ரூல் அவுட் ஹிப் ஃப்ராக்சர். ஓகேவா? ஸோ லுக் அட் தி ஆட்டிடியூட் ஆஃப் த லிம். த ஆட்டிடியூட் ஆஃப் த லிம் வில் கிவ் யூ a clue. And always remember, most of these patients, a human presentation will always most likely come to you in a case of spinal shock. So it is high likely, do not directly go in as a element lesion. The most important differential diagnosis of patient element lesion is a human in a state of spinal shock. சரியா? So human in a spinal shock தான். So what are the மூணு டேப்ல இருக்கலாம் important. So what are the basic differences between human and element? சரியா? So இந்த human and element என்னன்னு பார்த்தீங்கன்னா, as he has given in the இதுதான் basic differences. Okay, so corticospinal distribution, the patient can present as either hemiparesis, quadriparesis, paraparesis, and monoparesis also possible, especially lower limb monoparesis. We'll get to that. So any kind of presentation is possible in a UMN. Always remember, unusual presentations like quadriparesis or monoparesis, you'll always, hemiparesis is the only that you usually see. Quadriparesis is and monoparesis are very very rare, but quadriparesis and monoparesis na வேற lesions எங்கயாவது இருக்கா நீ first rule out பண்ணு. You have to confirm that it is a quadriparesis or a monoparesis. So element is predominantly either proximal distal. So that's it. Sensory distribution will more likely be a central pattern. In a human, very very less likely. Whereas in an element, you will have always remember it is in a case of peripheral nerve, it is stocking and glove and not glove and stocking. Okay, so it is stocking and glove. DTR, it is initially increased. Element, it can be normal or decreased. Superficial reflexes is decreased and normal. Associated pathological reflexes will be there. Sphincter is usually impaired. Muscle tone is increased. Okay, so pain can be. Then again, so this is the one that I wanted to tell you. So based upon the type of weakness, how can you localize the artery or a territory? So if it's an NCA infarct, the contralateral arm and face is more likely to be involved than the leg. Okay. So associated with sensory loss, yes, GTR is exaggerated. These are the possible accompanying signs. You'll have aphasia, apraxia, and all. So So in NCA, it is the contralateral arm and face. Okay, ACA, it is a contralateral leg more than the arm and face. Okay, well, internal capsule, as they always say, it's a dense hemiplegia. So it is always, everything is same. Contralateral face is equal to arm is equal to leg. Associated with no sensory loss. Like, see, lacunar strokes are only for pure motor, pure sensory, ataxic hemiparesis, dysarthria, clumsy hand syndrome. Okay, so this is one. So இதெல்லாம் cortical and subcortical. So what is the next vector? Then you have brainstem. Brainstem lesions will always present ipsilateral cranial and contralateral hemiparesis. Always try practicing that way. That way you'll remember where the lesion is in which side. So always try practicing it ipsilateral lesion, ipsilateral cranial and contralateral body. It is most likely to be ipsilateral element cranial with the contralateral body. Okay, so associated with sensory loss will be there. There is a thing called rule of 4 and brainstem. Okay, so 4 cranial nerves from above pons, 4 from pons, 4 from below pons, and 4 are midline structures, 4 are from the sides. Brainstem localization is a separate entity. I'll tell you that later. Okay, so cervical cord lesion, you'll have both arms and legs. How will you know it is a case of spinal cord involvement? Spinal cord, what are the features to say it is spinal cord involvement? Spinal cord involvement, if you want to say, the patient will have a definite sensory level. First point. Okay, the patient will have a definite sensory level associated with the bowel and bladder disturbances. Again, one of the important features of an ACA territory infarct is the patient is having an associated bladder disturbance. Bladder incontinence this patient can have because of involvement of paracentral lobule. Okay, so the patient is having leg monoparesis with the bowel bladder involvement. It can be spinal cord or ACA territory infarct is also possible. So don't always think that only a lower limb monoparesis could always be a local lesion or a spinal cord lesion. Can be an upper motor neuron lesion as well. So cervical cord, it is both arms and legs. Thoracic, it is almost paraparesis with bowel bladder dysfunction. Cauda icona, it is a cauda. The difference between cauda and cona is it is asymmetric cauda. It is basically your nerve rootlets. Okay, so it is associated with sensory disturbances and pain. So what is anterior ronsel? From here, your element lesion starts. Okay, so anterior ronsel, you'll have severe weakness with atrophy and fasciculation. When you say what does fasciculation tell you actually? Fasciculation tells you that there is an irritation of the nerve root or the anterior ronsel. These are the two structures which fasciculation, either fasciculation there is always an irritation of the anterior, either your anterior ronsel is degenerating or there is an irritation of the peripheral nerve root. This is what it always tells. So to say it is an element lesion, it is always atrophy, fasciculation with the bulbar weakness. Okay, so if a single nerve root, again a particular segment is affected, this is so element lesion starts from anterior ronsel, then your anterior ronsel, then your nerve root, dorsal and ventral nerve root, then it becomes a radical, then the radical becomes a plexus becomes the nerve. From the nerve, it goes to the neuromuscular junction, nerve to the neuromuscular junction, then you have the muscle. Okay, that is how the element, this is how you classify element lesion. First, you have to classify it as human or element. Then you have to first you have to find out if it is a weakness, it is a neurological weakness, or any other cause of weakness. Can be because of associated pain or associated bone pathology. First, you have to find out whether it is a pure neurological cause of weakness. And after finding out it is neurological cause of weakness, you have to find it out whether it is a human type of weakness or element type of weakness. After realizing that it is an element type of weakness, you have to localize the site. This is how we usually approach. Okay, so then you have to localize the site of the lesion. So this is mononeuropathy and polyneuropathies. And what are the neuromuscular junction? So I'll tell you some important points about this. What are the associated things that you must look for? So in an NMJ, always try to look for a fatigable weakness or a diurnal variation of weakness associated with the patient is having when you say when there is a patient is having any sort of weakness, always try to look at the cranial nerves. There is associated cranial nerves. It can be a brainstem or a neuromuscular junction. Okay, always try to look at the cranial nerve, not only the patient's body. Always try to look at the face as well. So muscle is again proximal more than distal. Okay, so these are the things that I wanted to tell you. Then one more thing is regarding the onset, you said, right? So regarding the onset, you classify it as any neurological complaint. The three major things that you must ask is duration, onset, and progression. So that is what is going to give you a clue. So duration, onset, and progression. So what is the duration? This patient is having an acute, subacute, or a chronic onset. What are the causes for an acute? Basically, broadly saying, acute is always a vascular event. Okay. So acute is always vascular. It can either be an ischemia or an infarct or or an hemorrhage. Okay. So this is the thing that I wanted to tell you. Then if you see these are some of the associated signs. Okay. So if you look at the corticospinal tract lesion, you'll have a monoparesis or any pattern is possible, preferably pyramidal tract of weakness. Okay, what is the pyramidal tract of weakness? Distal more than proximal, with the fine muscles of the hand being involved, and with the tone, the preferential tone pattern and the preferential weakness pattern. Okay, tone is always spastic, but always remember, always the patient, there is always a possibility of patient being in a state of spinal shock. The volume will be normal, except in case of prolonged cases where you can have diffuse atrophy. Fasciculations will be absent, ataxia will be absent. Ataxia again rules out cerebellar involvement, not necessarily, can be involved posterior column also. Okay, so deep tendon reflex is usually increased, and unless it is acute, associated abnormal movements are absent. Pathological movements can be present. So this is a cortical lesion, right? So what is the subcortical lesion? Is the extrapyramidal syndrome. Extrapyramidal lesion, there will not be any weakness, or there is usually a mild weakness which is very subtle, cannot be appreciated that much. So tone is always, there is a rigid type of hypertonia. Volume and contour will be normal. Your volume is normal. Fasciculations will be absent. Ataxia will be absent. DTR will be normal. The only thing it is this abnormal movements. Okay. So this abnormal movements is thing that you must know. So that is regarding the basal ganglia or extrapyramidal symptom. Next comes the cerebellar lesion. Remember, cerebellar lesions will never produce weakness, only hypotonia. And there are certain rules of cerebellar. Cerebellar lesions never produce weakness, only hypotonia. Lesions are always on the same side. Okay, so cerebellar lesions, there will not be weakness, but your ataxia can stimulate the patient being weak state. So tone is always hypotonia, always on the same side. Volume will be normal. Fasciculations will not be there. Ataxia will be present. Deep tendon reflex, the only thing we can have is pendular knee jerk. Pendular knee jerk. Okay, abnormal movements. You can have an intentional tremor. Pathological associated movements is absent. Okay, abnormal movements is sign of actually your basal ganglia or extrapyramidal system being involved. Pathological associated movements are nothing but your frontal lobe release signs, grasp, sucking, snout reflex. Okay, so regarding the brain, you have classified it as cortex, subcortex, and the cerebellar. So regarding the brainstem, there is always, as I said, ipsilateral cranial nerve with contralateral hemiparesis associated with sensory and motor. Both will be there. So regarding the element type of lesion, this patient, if it's an element lesion, can be focal or segmental. Tone is always flaccid. Atrophy is very, very common. Fasciculations are common. Ataxia will not be there. DTR will be decreased or absent. Abnormal movements cannot be there except fasciculations. Okay. So regarding the nerve root, it can be focal or segmental. It is flaccid weakness with atrophy, segmental in this. So NMJ weakness, again, always try to look at the fatigable weakness or non-fatigable weakness associated with the bulbar cranial nerve palsy. Okay, the associated with dysphagia, dysarthria, always try to ask these cranial nerves 5, 7, 9, 10, 11. Okay, 5, 7, 9, 10, 11, and 12 also. Always try to look at these cranial nerves again. So this is NMJ. Muscle can be normal, or your weakness is usually proximal or is usually diffuse. Okay, tone is usually normal except in case of severe weakness or severe myopathy, you can have a decreased one. Volume, it can be either initially hypertrophied or pseudo hypertrophied. Associated, everything will be normal. DTR, remember, the only thing that you must be very confident is regarding the DTR. Regarding UMN and LMN, UMN is always exaggerated, LMN can be decreased or absent. Regarding all the others, your deep tendon reflexes are usually normal, uh, except in severe cases. Okay, except in severe myopathies, it can be decreased. And similarly, NMJ, when you say it is an NMJ, you must have normal DTR reflexes, except in case of severe weakness. Even then, the DTR would be normal, but just for the muscle weakness, you'll have difficulty in eliciting the reflex. That is the only thing I want to tell you. Okay, so non-organic disorders, I think you'll know. So regarding the etiology, what is it that I want to tell you regarding the etiology? Etiology is usually duration, onset, and progression. Duration can be acute, subacute, or chronic. So acute is always a vascular event. and can be another possibility is a demyelinating event. Okay, subacute more likely to be a case of infections like your meningitis, cerebralitis. This is most likely acute can also present infection can also present as acute in the form of epidural abscess, epidural abscess, subdural abscess, in the intracranial abscess also. Okay, so that is one thing. Subacute is infections and your intracranial space occupying lesions. So this is these are two in subacute. What is chronic? Chronic can be degenerative or this familial hereditary or degenerative disorders like your Alzheimer's or hereditary in the form of spinocerebellar ataxia. These are the broad classifications of weakness. Okay. Remember, first try to find out whether it is a neurological weakness or not. Then you try to classify, because then again, I've seen many cases of patient being classified as a low limb monoparesis. Ultimately, the patient being end up in having either a case of septic arthritis or a case of fracture femur. So if the patient is having a monoparesis, first try to do an X-ray the lower limb or X-ray pelvis. Then you try to look at the diagnosis, because those are certain unusual size of presentation. Then you'll have facial-brachial monoparesis and all. Facial-brachial monoparesis again. These are the three tabular columns which I want you to know. Okay, so that is from my side. Anything else? We'll discuss everything once we go in detail regarding the other weaknesses and all. So this is one thing I wanted to tell you. So if you have a human pattern of lesion, try to look at the go for a CT brain, or if you feel that it is an element, but the patient being in a spinal shock, it is very, very difficult to realize. So try to do a CT brain at the emergency at possible. Then once you know it is an element lesion, you can take your time. Then you do an NCS or an MRI spine. There is always you can wait for that, but you can always try to do a CT brain, then try to rule out others. Okay. So anyone else? Preetham, you finish your presentation now.
Yeah, okay, sir. I'm not sure where I left off. I'll start from the final case. The final case is a 45-year-old man, a middle-aged man who presented with progressive weakness starting from his upper limb, and it progressed to lower limb, and its duration is 8 months. So what we see is a chronic history of weakness that is progressive. Now, when we look further into the history, we find that he's been having a difficulty in speaking and slurring of speech for 3 months, along with a difficulty in swallowing since 1 month. Now, looking at a difficulty in speech at first, you would probably think it's a cerebrum involvement. But then, he's having a difficulty in swallowing as well, which is not typical of a cerebrum involvement, but more of a brainstem involvement. So this patient's having weakness along with the involvement of cranial nerves. Now, we'll move on to chronic. So, we'll move on to examination. Now, in motor examination, we see that the patient has atrophied muscles. Now, when we look at atrophied muscles, what we think is an element or a myogenic cause. So it's either L or M uh, of all four limbs. Now, when we move further into examination, we find that the patient has a spastic tone with exaggerated reflexes. Now, we see a combination of both LMN and UMN over here. The only case where I talked about a combination of UMN and LMN initially was a spinal cord lesion. So, in a spinal cord lesion, typically you would see LMN at the level of lesion. So, suppose let's say T4 to T6 was affected, the muscles in T4 to T6 would have all the LML features, whereas the muscles below would have all the UMN features, ruling out spinal shock, obviously, after the state of spinal shock. Uh, But then what we do not see is a mixed element or human feature in any muscle, which is seen in this patient. The patient has atrophied muscles, the same muscles showing an increase in tone and reflexes. Now, on further examination, we see that sensory and bowel and bladder patterns were normal. So, whatever disease this is involving only the motor system, sparing sensory and other systems. Now, the patient also had a typical oral cavity examination finding, which I'll talk about once we land on the diagnosis. Now, so the case, in summarizing the case, we have a middle-aged man with progressive weakness since 8 months, which is a combination with associated slurring of speech and swallowing, suggesting a possible brainstem involvement as well, or cranial nerve involvement. Along with that, he has both the UMN and element features without sensory or bowel bladder involvement. Now, this is the MRI finding of that patient. Now, the findings we see are fairly subtle. What we see are hyperintensities on a T2 image in the posterior limb of internal capsule. And in the B image over here, we can see the same hyperintensities extending down in the internal capsule. Now, this is known as a typical wine glass appearance. And the disease we're looking at here is actually a motor neuron disease, ALS, amyotrophic lateral sclerosis. So, and the oral cavity examination that you would see in this patient is tongue fasciculation. So, this is one of more of a rare neurological disorder where you see both the combination of human and element. Now, but using this pattern, we were able to narrow down like what could and could not be the differential diagnosis. We could see that it was both a combination of human and element. It had involvement of cranial nerves and it had a chronic duration. So, yeah. So hopefully from this presentation, you got a better idea on how you can like narrow down the pathology and have a more structured approach to approaching a patient of neurological weakness. Thank you.
That was very nice presentation.
Thank you, sir.
So basically, the only disease have to have both human and element signs in a single particular limb or a particular region is motor neuron disease. Again, don't get confused with the motor neuron diseases and motor neuron disease. The term per se motor neuron disease refers to ALS alone. Motor neuron diseases are a broad term which includes either predominant motor neuron disease or a predominant element type of motor neuron disease or both. The term per se MND only refers to ALS, whereas motor neuron diseases refers to a group of all the other diseases. Okay. So only disease to have both human element signs is ALS, amyotrophic lateral sclerosis. So that is one thing. And regarding the others, name some diseases which affect the central nervous system can present with paralysis. This is very, very important. Name some of the diseases which can present to you with paralysis.
Polio.
Yes, polio. Agreed. Polio affects the
anterior horn cell.
Anterior horn cell, bulbar nucleus of the cranial nerve. That is why when you think there is something affecting the anterior horn cell, always try to look at the possibility of bulbar nucleus also. Polio is one. There are a lot of infections. What are those?
Botulism.
Botulism. Yes, agreed. What does botulism always mimics?
Myasthenia.
Yes, botulism always mimics an NMJ lesion. Okay, botulism is NMJ basically. So always remember when there is wherever you say NMJ as a DD, there is always a possibility of botulism as well. So botulism is one possibility. Then
HIV related.
HIV can present as anything, polyneuropathy, mononeuritis, anything can present. Agreed. Then Clostridium எல்லாமே சொல்லலாம். Tetanus. சரியா? Tetanus, botulism, polio, leprosy. Don't forget leprosy, man. Leprosy, when the patient is there is area of sensory loss, look for always patches. Okay, leprosy is still very, very common and prevalent. So leprosy, always try to look at area of sensory loss, sensory patch, then try to look for thickened nose. Okay, so Other things are syphilis. Don't forget syphilis. Okay. Any other
TB,
thing?
TB,
TB can present. Okay, TB can present as infection. Then one more important thing which presents as bulbar palsy, dysphagia, dysarthria occurring as a post-infectious sequelae.
rabies,
Rabies, agreed. Then one more,
Diphtheria.
diphtheria. Yes, diphtheria usually occurs as post-infectious complication. Always remember that is why in the protocol when you're discharging the patient, you're supposed to follow the patient in his home for at least 1 month. They'll follow it up. They'll follow him up because the patient usually there are many instances last year where the patient has been discharged. The patient went home and died because of aspiration. This is what has happened every time last year. This has happened a lot of cases. So every case was asked to follow up in their homes by the PHC officer for a month because they'll ultimately these patients will land up in dysphagia. Dysphagia. They died because of aspiration. Always try when you're discharging a patient of diphtheria, look at the palate and the fossils and then discharge the patient. Otherwise, it is very very difficult. Okay. So any other infections? Still, there are very rare infections like West Nile virus, HTLV1, HTLV2. Okay.
CJD.
Huh?
Prion diseases.
Okay. Prion diseases. Anything else?
Herpes.
Okay. So that's all. Then anyone else wants to say something? We'll close up then. Thank you.
Okay, thank you, sir. Thank you.